2:58 झाले. 1-2 मिनिटात चालेल.
हो 2:58 झाले. सर स्पीकर्स वगैरे आलेत का? नाही आलेत ना?
कोण?
आपले स्पीकर सर शिराज सर वगैरे.
मला मेसेज आला आहे भूपेशचा काही प्रॉब्लेम आहे. सो ही मे नॉट बी. ठीक आहे, आय विल कव्हर दॅट. दॅट्स नॉट अ इश्यू. स्मॉल प्रॉब्लेम विथ भूपेशचा एक रिलेटिव्ह हॉस्पिटलमध्ये आता ऍडमिट झाला आहे. सो
ओके सर, इज इट रिलेटेड टू कोरोना और समथिंग एल्स?
नाही, सम कार्डियक इमर्जन्सी इज देयर.
ओके 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 सर.
ही हॅड टू रश. त्यामुळे प्रॉबेबली हिज प्रेझेंटेशन शिराज विल गिव्ह, असं काहीतरी करतील ते. We'll start in a minute.
Yes?
Yes, Vishnath sir.
Now it is live.
It is live, na? Okay, thank you. So can you please share the link, Vishwanath sir, so that I can share it to Boris sir as well?
Yeah. Just one.
Yeah.
Should I need to share the link?
Yeah.
Yes, sir.
Okay, I'll put it in the chat box.
Sir, chat box. Okay, fine. Yeah, chat box also fine.
Chat box वर काय?
ना chat box वरती ते टाकतात आता.
Okay.
आलं sir.
Good afternoon, sir. Satish sir.
Yeah. Good afternoon. Okay, this is the link for YouTube.
Yeah.
Yes.
Okay, very good. Okay. Yeah, I can see that.
Good afternoon, sir. Satish
Yeah.
sir.
Good afternoon. Yeah. Good afternoon. Okay, very good. Let's start. I would just start,
Okay, sir,
and
let's
then
start.
Jayesh, you can take over for a minute or so.
Okay.
I welcome all of you for our next session on mid-zone surgery. This is the 6th in a series of 8. And today we are going to talk about mid-zone stenosis and surgery. It would primarily be important to note that mid-zone surgery is primarily disc level surgery. So what we really do is all those who do transforaminal endoscopy for the disc would be very comfortable doing this surgery. More about that we will talk very soon. Jayesh, you go ahead.
Yes. Okay, so good afternoon to all the respected delegates and the faculty members. I, on behalf of Alembic Pharmaceuticals, take this opportunity to welcome you all for the Mission Spine course which you are having. That is series on transforaminal lumbar stenosis, surgery, specialized and under local. Today is our 6th webinar, as sir correctly mentioned, that is mid-zone stenosis surgery. Today we are going to have this topic, and as the above mentioned topic, we are going to have Dr. Satish Chandra Gori sir as the moderator for today's session, and we would have eminent faculties from the Mission Spine, Dr. Bhupesh and Dr. Shiraz Ahmed Munshi sir as speakers. So without further ado, I would request Gori sir to start off with this session. Sir, over to you.
Yeah, thank you very much. So as I mentioned, the mid-zone surgery is essentially surgery which is done at the disc level. And there may be some confusion in the mind of some people, especially about the anatomy. So what I'm going to do is to give you a glimpse of the basic anatomy related to the middle zone surgery. So, okay, are you able to see my screen well? Hello. Are you able to see my screen?
Yes.
Yeah,
yes,
okay.
Sir.
Fine. So we start with this, and I think there is some chat message. What is it? Okay, yeah. Thank you. Thanks for telling me that it's working properly. Sometimes there is a little bit of confusion otherwise. Okay, the first thing which I'd like to bring to your notice is that as a clinician, you will be seeing patients who will have disc-related sciatic pain, and you will have patients who will have canal stenosis-related claudication. Actually, there is no need to confuse one with the other. But there are two issues which have to be clarified. Issue number one is we have our decision making in stenosis apparently based on the images alone. Of course, symptoms do matter, but most of the decision making about surgery is based on the images. So the first paper which I have just included here, which I'm going to send you on the chat window as a link, and all those who are on laptops or desktops should be able to download. One of you, I request to sort of collect those papers and send it by email to others, or all of you, those who desire, you can put your emails so that I can send it at the end of the talk. So the first paper is about hemodynamic changes in the lumbar nerve root, entrapment because of stenosis or entrapment because of a disc herniation. Now, there are a lot of advances which have come up after this paper in 1995, but this paper is specifically talking about this very simple basic question, that can we distinguish in the image a disc herniation or a stenosis related problem. I mean the problem related to hemodynamic changes. So you can read that paper. I'll send you the details very soon. Now the second paper which I'm talking about is, you see there are a lot of studies world over, and these studies are done especially with the intention as to classify all these patients. Somebody has raised a hand. So is the issue settled? Okay. So world over, studies are done and attempt is being made to classify various patient categories based on the symptoms. Now, as all of you know, let me tell you something very simple. When I was a resident, when I started doing my MS way back in 1980, almost 40 years back, that time it was very vague. We used to probably be so confused about back pain, sciatic pain, claudication, and hundreds of ideas. And in those, we used to have Mercer's textbook of orthopedics, a typical sort of a lengthy, well written book with a lot of ideas, but not very clear. And we also used to follow Campbell, of course, which is still followed today. So, classification of patients based on symptoms was very vague. And we were given an idea in those days, about 40 years back, that patients cannot be classified very well because there are multiple causes and you cannot diagnose maybe about 50% of them. This was an idea about 40 years back. With the advent of better diagnostic modalities, right from CT scan, cross sections of the spine, CT myelo, then discograms, and then, of course, MRI scan, things have improved quite a bit. So, the second paper is talking about the descriptors or the words used by the patients in narrating their symptoms and how the patients are classified. Now, I can tell you that on that count, I have come out with my matrix, where all of you probably by this time are aware that there are 6 groups of patients based on symptoms related to back and leg pain. First group is where the patient has knee, heel, groin, or coccygeal pain, which is probably because of an annular tear which is leaking, giving rise to chemical radicular involvement. The second is where the patient has back pain, which is because of disc fragment being trapped in the annular tear, so it doesn't come out or go back in and gives rise to continued back pain, especially when the tear is in the middle, that is in the midline posterior annulus. The third group is back pain because of facet. The fourth group is discogenic sciatic pain primarily. Fifth group is claudication with a stable spine, and sixth group is claudication with an unstable spine. Now, the whole thing can also be arranged in this fashion, that you have patients around 20s, age years 20, who will have knee, heel, groin, coccygeal pain. Patients around 30 would probably have back pain because of disc. Chronic back pain, non-healing annular tear is the main cause. Around 45-50 will be patients with sciatic pain, and around 60 will be back pain because of facet, and above 65 will be those patients with canal stenosis. Now we go quickly to our mid-zone anatomy and then start appreciating the basic points which are important. Now, if you see this image, what I'm trying to show you is a 4-5 level bony anatomy where you see the foramen of L4-5 from the right side, where you see the L5 superior articular process here. I think I will take a marker probably. Okay, this is the marker. Okay. So you will see this is the superior articular process of L5. This is the inferior articular process of L4. This is the pedicle of L4, and the nerve, the L4, will come out and go out of this. Now, everything which is above the superior articular process or which is above this lower end plate line of L4 will be upper zone of the foramen, that is this area. Everything which is below this end plate up to the other end plate, that is at the disc level, is our middle zone. Now I have this image which I have created out of a 3D software, where you will find this thing which is seen here is the lower end plate, say L5 end plate. This is the upper end plate. This is the superior articular process. This is a little oblique rotated picture, but the important point is you will find the posterior part, posterior wall is all bony. Okay, this is important. And this posterior midline is at a depth. What I will like to repeat is if you look at the spine from the side, a lateral view or a sagittal view, you will find that the lamina in the lower portion is like a wing. It is raised towards the posterior aspect, and it is here, say somewhere around the mid pedicle level, that the lamina starts becoming more posterior, and above that probably it is not so much winged. Now I will like to bring to your notice these important points. If we look at the ventral dissection of the ligamentum flavum, then we will find that below the pedicle would be the nerve going out, and this will be the upper zone. The end of that upper zone, that is the lower border of the upper zone, will be tip of the SCP shown by this star, and this star showing the ridge. The ridge means the lower border of the facet joints or the facet joint edge. And this blue zone, this blue thing which I've drawn, not blue zone really, I used to call it as orange zone, is really the area which is the roof of the middle zone, which extends right from the mid pedicle line to the other mid pedicle line. And you will find that above is the bone, below again will be the bone. In between window, that is the interlaminar window, is covered by the ligamentum flavum. But please note, the lower border of the ligamentum flavum is dorsal to the lamina, and cephalad border of the ligamentum flavum is ventral to the lamina. So please remember these anatomical facts. Now, what we will be doing is, after looking at this anatomy, we go further. And here, what I have done is I have gone ahead from the front, from the ventral aspect, and I'm looking at the mid zone. This is the lower end plate. This is the upper end plate. This is the superior articular process of L5, for example. This is L5 end plate. This is L4 end plate. This again is the superior articular process. Behind that is the facet joint. And this is the posterior midline, which is so far in depth. What I mean is the lamina is not in one plane. This is like this. This is quite in depth. Again, the same thing with a little alteration. The alteration is we are in the midline here, and here we are looking at paracentral osteophytes, which are very common. This is the osteophyte for L5 end plate, osteophyte for L4 end plate, and tentatively this orange line is the traversing nerve, which will go down and go out. The dural sac will be from here to here in the posterior midline, and this would be the dorsal aspect of the dural sac in the midline.
Sir, voice clear नाही sir.
Yeah, just give me a moment. There is some issue with the power source. Now is it okay?
Now it is fine, sir. Yeah.
Yeah, it will come up. Just give me a few seconds. Okay, now it should be all right. Yes?
Yes, sir. Fine. Perfectly fine.
Yeah. So here what we are looking at is the posterior midline. This is the paracentral osteophyte from the lower end plate. This is the paracentral osteophyte from the upper end plate. But please remember, these osteophytes are ventral to the dural sac. This is the orange line is the traversing nerve, and the dural sac will be somewhere here in between, from here to here. And this, as I was mentioning, is a superior articular process related hypertrophic tissue. So just imagine what is happening around this nerve and the nerve which has gone out in this foramen, the exiting nerve above. The same thing which is seen with the rotated vertebral bodies. Here, I would like you to appreciate one important point, that this is the superior articular process, and we are this is the pars interarticularis. This is the superior articular process, and we will be coming in, and this is the reach where this flow of the SAP will be changing towards the canal. Okay, so this will be subarticular area somewhere here, and this will be quite in depth. What I'm trying to convey to you is that this point is not very close to the dorsal aspect of the dural sac, and we are in no way concerned with this area. And all that talk of posterior midline removal of ligamentum flavum, etc., is absolutely irrelevant. The ligamentum flavum will be there here, definitely, mainly the ventral aspect of the upper lamina, coming from below, from here, breaching the central minor window. But please remember, here it is attached to the bone. It is not bulging at the attachment. It may be bulging somewhere here. This is the traversing nerve. Now, what is that in the... Why is it not clear? Okay, just give
सर
me...
ऍक्च्युली मी इंटरप्ट करणारच होतो. मध्ये येते आणि जात आहे, म्हणजे मध्ये इट इज व्हेरी क्लिअर इन बिटवीन अँड अगेन देन इट स्टार्ट्स टू क्रॅक.
Is it okay now?
Now it is fine, sir. Yeah.
Yeah, okay. So I would probably sit a little nearer to the mic.
Okay, sir.
There are one or two more slides, not many. Okay, so here what we are looking at is the end plate of, say, S1, and this is the lamina of L5. This is the superior articular process of S1. Again, same thing. Now here, what I'm going to do is, this is the upper end plate. As you can see clearly, I've taken a cut there. This is the upper end plate. Now this is the mid zone. So in the sides, you have the SAP, the outer surface of SAP, inner surface of SAP. Okay, this is the way it is. Now there is another message I'm getting of your live video, then bandwidth. Yeah, okay. Yeah, I agree. So I have stopped my video. Maybe it will improve the... Again, is the voice clear?
Yes, sir. Now it is clear.
Okay. So this is what I have just tried to convey to you. Now the same thing being seen from left side, the spine rotated towards the right. This particular thing is one end plate, there is another end plate. So between these two is the disc, and at the back will be SAP. This area where the ligamentum flavum will be there. This is to highlight the depth of that laminar V. and to make you aware that what we are trying to emphasize is I'm going to come in the foramen here and I'm going to work on this area. I'm not going to work on this area. Now the same thing being shown from the other side. So this is from the right rotated area. Now you can imagine what I've done. I've taken a cut here of the bony model at the upper end blade level. So again, I'm repeating. This is the lower notch, pedicle, superior articular process, inferior articular process, facet, lamina, the midline, the other side. And between these two plates would be the mid zone. And this is the posterior wall of the mid zone. Now, all these years we have been told that we do this laminotomy, a little bit removal of this upper lamina, and then we remove the ligamentum flavum. Absolutely irrelevant. It has nothing to do with the symptom causing areas. We can always debate that point more once we start seeing the anatomy much, much more clearer. Now, last time when we talked about back pain, etc., somebody asked me about an image for the sinovertebral nerve. So these are the branches. This is the sinovertebral nerves shown by the star, which is coming towards the axillary aspect. This is the dorsal ganglion. So this was the image which was to highlight that. So what I have tried to convey to you is proper understanding of the anatomy and visualization of the anatomy is absolutely important. Surgery in case of stenosis is guided by images, but I would very strongly suggest to you that all of you may take a plastic model or a bony model in your hand and try to imagine the ventral anatomy. I mean, uh, just give me one moment. Okay, somebody asking me how do I log in. Okay, so as I said, ventral dissection is important, and we have to look at the depth of the lamina and appreciate that we are not really going at the posterior midline, but we are more below the facet, we are more in the foramen, we are more on the tip of the SAP, and we are more on the end plates where all those uh, osteophytes are going to be there. So this is what I wanted to share. Now, if you have any questions on this part, please ask me. Otherwise, what we will be doing is we will be going ahead with Shiraz if he is here. Mm, Shiraz, okay, you are here. So, Jayesh, I think your screen share is going on. If you could stop that, we will be able to go for Shiraz's
So my
presentation.
signature is not going on.
Okay, yeah, that logo is there. Fine.
Yeah.
So, Shiraz, you can take over. In the meantime, if there are any questions, please ask me. What I've actually tried to do is to clarify the anatomy as I understand it. And I'm sure that you would agree that our concepts about posterior midline surgery as applied to the mid zone or as applied to the stenosis surgery need change. We cannot continue with the old ideas where we are only talking about laminotomy, laminectomy, undercutting of the facet, etc. It is absolutely not relevant to the symptom causing area there or the structures there. And if you are still not convinced, I invite you to maybe one of our cadaver workshops where we can always sit down and dissect the cadaver and be convinced that what we are talking is the real science. So, Shiraz, again, would you please start your presentation?
Yeah, sir.
Yeah, please go ahead.
Okay, sir. Just 1 minute, sir. Okay, sir. I'm just taking 1 more minute. I just
Yeah, no problem. You take your own time, no issues. So, in the meantime, what I'll do is I will try and put 4 files here. Now let me explain to you what files I'm sending. And all those who are on the laptop or desktop, they will get these files. There are 2 papers which I just mentioned as my first slide, and these are about the clinical aspect and about the MRI thing. So these are 2 papers. Then I'm also going to send you. Uh, there are 2 books which I would like to share. These books are basically related to 2 important, let's say, 2 important concepts in transforaminal endoscopy as such, and the evolution of transforaminal endoscopy. Now, what has happened is, one concept is what many of you may be knowing is called as um, automated percutaneous lumbar discectomy. Now, this was promoted by a person named Gary Onick. And Gary Onick is a radiologist, and he proposed a 4 cannula which was put inside the disc, and automated churning of all the loose material from the disc was done, and the central part of the disc was decompressed. In those days, the ideas were more towards disc decompression. So that is one of the books. And the second book is by a very celebrated Swedish ortho spine surgeon, Gunnar Andersson. You can read his book. It is an old book, but it will help you in improving your concepts. And Gary Onick's book will give you excellent illustrations about the technique. So the first book I'm putting now, it is Atlas of. Okay, and then just let me know if you're receiving this, especially those who are on laptop or desktop. So are the files received? Yeah. So try to search biochemical origin of pain. It is there on the net. You can just search it that way. I think I have sent 1, 2, and 3. Lumbar spine syndromes. I think I sent the same file twice, and Atlas once. Okay, so the other file and the Atlas I will send. The Atlas, especially as I mentioned, is very good. The illustrations are excellent, and you will be able to enjoy the basic thinking in it, where the probe was put inside the disc transforaminal and a discectomy automated was done. Those who have not known about it probably will be more excited, because this is one of the important developments during evolution of our transforaminal endoscopic surgery. Now there is okay, Shiraz, are you ready now?
Yes, sir, I'm ready now.
Okay, I thought you were still having time. Okay, then you go ahead.
Okay, sir. Yeah.
Yeah. Yeah, please go ahead.
Yeah, sir. I'm just
Yeah,
connecting my
okay,
screen.
okay, fine. If there's a silence, then you feel as if.
Yeah. Okay. So, today, sir, my partner, Dr. Bhupesh, his brother is having some real medical emergency. So, he's not around. So, I'm going to take some of its part. And maybe in the next session, Bhupesh will join us. So, today, sir, we are going to discuss more about the mid-zone surgery. So, sir, already you have explained that what is the three zone, but I just want to go ahead further, and I'll speak little more about the spinal stenosis. So, sir, basically, this spinal stenosis is a narrowing of the spinal canal where uh, the already gradually narrowing spinal canal is now not accommodating the nervous tissue, and that leads to some changes. And usually, these are the dynamic changes that these patients are usually the more than 80% of the patient, they are symptomatic only while they are standing and walking, and if they are resting, they are okay. So it has to be some dynamic changes, and this dynamic changes lead to something which will have the consequences to the patient, and the patient start developing symptoms while they stand for some time or walk for some time. So these are the symptoms. So the patient either feel the back pain or the radicular pain, and this can be a combination or something less or more, but usually the patients are having the classical tingling and numbness, heaviness in the leg, and those patients who are having the continuous symptoms even without like there is no dynamic changes, and the standing and walking, if it is making more severe, then it has to be a very critical stenosis, and those patients require decompression urgently. So what the question is, what actually we are relieving by doing the decompression. So as we discussed that there has to be some dynamic changes. So the vascular congestion is one of the most important factor that because of the upright position, the patient develop upright position, and there is a congestion of the vasculature inside the spinal canal, and there is a dilatation, and this dilatation leads to the further narrowing of the canal, because the standing and walking position is a gravity assisted blood flow to the lower part of the body. So this will have some more most important impact, and definitely because of this vascular congestion, there is a further ischemia. So like this is more like a varicose vein where the patient is having the actual more blood, but since that part of the blood is not used, and they are just staying there, so that will lead to the neural ischemia and associated some inflammation, and this microadhesions. So this microadhesion is also one of the very important factor where the this vasculature is having some adhesion, some narrowing at some part where there is adhesion. So because of that, that some part become the dilated and tortuous, and this leads to the dynamic symptoms to the patient. So, sir, you already have explained the anatomy of the ligamentum flavum, but the most important, the anatomy that we are not very much aware that this is your slide only. There, it's showing the dissection, and dissection from the ventral side. So, like this is after removing the vertebral body. This is what we can see. So you can see the ligamentum flavum extend up to the foramen, and it goes up to the below to the pedicle also. So this is very important to have the understanding that that our philosophy and what we are talking is that we believe that the lateral canal stenosis is the most important pressure area where there is a compression rather than the central compression. So usually uh, with the posterior midline surgical technique, we are not able to completely decompress the lateral canal, and that's why we are not getting the great result. So, and you can see this is also the same area where there is a compression, and this is the area where the exiting and the traversing route both are going from here. So this part need to decompress very nicely to achieve the good result. So we already have discussed before about the zones. I'll just go very fast. So like very simple explanation for three zone uh, the upper zone is mainly the area which is above the tip of the superior articular process, and this area usually there is the big problem associated with the travel exiting route. So usually we say that upper zone surgery is morely to decompress the exiting route, Middle zone, usually we find the difficulty with the major disc herniation and the ligamentum flavum. So this is going to decompress your both traversing as well as the exiting route. And the lower zone surgery usually that is for exit traversing route pathology. So that's why here in this technique of um, uh, uh, going to the decompressing the mid zone, it's a almost similar approach what we used to do for the disc surgery. So I will not go into the again detail about the three different zone, but again this the mid zone is a perapedicular segment and where we are going to decompress this number two area. So now we have some different instrument which we use, and usually these instruments are go along with the line of the endoscope, and you can mainly the decompress the foraminal area to expose the phlegm and the more medial structure to the facet joint. So these are the instrument. The most important instrument is a flexible burr. So like you can see, this flexible burr is straight, and with some manipulation, you can make it the tip little bend. So this bending will allow you to go along with the line of the endoscope. So currently, the most of the endoscope what we are using is around 25 to 30-degree scope, and this with this angle. So whatever the picture you have is not in the straight line, but it's having some angle. So that's why the usually the very straight instrument that doesn't go along with the line of the endoscope, and that's why we have the more difficulty. So we have developed this new kind of instruments which are like, so this flexible bar goes up to around 30-degree, and once you pass through the endoscope, you can just make it rotate and it will go further. This is also one of the very important instrument is the 45-degree annulus cutter. So you can see that this is the fixed instrument, but the angle is 45. So you can see that whatever is there on the roof, so you can easily catch it, and even if you want to cut it, you can do it very nicely with this instrument. Similarly, this is a upbiting forceps. So like you see that we know that usually by removing the tissue from the roof, any instrument which is having the straight jaw, it will not catch it. But like you see, this is having the upward the movement. So like this is the very useful instrument to hold something and to take it out. So this is also very important. And there are some other instrument, and this instrument like what we discussed about the flexible burr, so that is going to give you the more access to that special area where you want to go and you want to work. So this instrument like you can see, these are the trifine, these are the some the bone drill, this is the rasp. So basically with this you can do some bony work, and you can take out the, or you can just trim the edge and something to make the foramen more wider. So once you make the foramen more wider, then you have a better option that you can do some leverage, and you can go to the phlegm which is more medial to the superior articular process, and you can work with this. So like how we do the surgical steps. So basically there are two thoughts that either we can go more flat, and we can just go to the lower part of the superior articular process, and we can just drill it, and once we drill it, and it will expose the ligamentum flavum nicely, and then you can work it very well. So you can see in this video that this is a diamond timber. Now I'm making it a little more flex. So like while working, you can make it more and more flex, and this will work, and this will go along with the line of the facet, and you can keep on drilling the facet, and once you expose the ligamentum flavum, then you just go with the those upbiting instrument, and you can work with it. this is one of the more video where you can see that. So you see, this is also the very important. This was having the bilateral stenosis, and so we already did on the one side and other side. You can see that we can go and we can work with the drill. So this drill is one of the very important tool to work on the bony area, and these are like the very fine and very precise drill, and these are available with 3 millimeter, 4 millimeter diameter cutting tip. So that way you can do the very nice job, and you can very precisely, and the most important is under vision, and above all that all this we do it under local anesthesia. So when we do it under local anesthesia, that the patient is awake, so like you are not worried about anything, and even at any point of time when you touch the nerve root or something, the patient will tell you that, okay doctor, I'm having something. And this is, you see, this is a this is not the diamond, this is the cutting edge. So usually this cutting edge is very very helpful and very useful to do the decompression and faster, but there is some problem associated with the bleeding. So diamond tip is preferable here, where the diamond will turn the bone into the dust, and there will be immediate automatic sealing. So this sealing will have the impact, and so there will be a very less oozing coming from the bones. So, and then we all know that the bone oozing is one of the very difficult issue where we can have some trouble. So once you go with the angle. So now this was I was discussing that we have two options, that we can go with the more oblique angle, or we can go the more flat. Now with the going with the more flat angle, so you will just be able to work on the edge of the facet, which is making the boundary of the foramen, and then you can take out the disc bulge, and you can take out the phlegm. But with this there is some question whether the working only on the roof in the especially in the case of the lateral canal stenosis is important, or you have to work ventrally on the floor also. So like this is we can discuss here also, and I always believe that I always like to work on the floor as well as on the roof. So where you have the good decompression from the both side, and usually these patients are having very high calcified ligamentum flavum, and calcified annulus also. So even removing this the calcified flavum, it will decompress the nerve more effectively. But there is some problem associated with this, is there is a more post-operative pain to this patient. So I always like to work on the floor as well as on the roof. So the roof is a phlegm, and the floor is more of a disc outline. Now there is a very special consideration. We have to look for those patients who are having the alpha S1 disc. So those patients, because here in the mid-zone surgery, you have to go along with the line of the disc. So if you have a patient who is having the high iliac crest, or those patients who are having the collapsed disc, or the patient is having the central herniation. So these are the three group of patients where you will find difficulty because of the iliac crest and the alpha S1 area. So here the best option for this is you can go transiliac. So now this is the MRI of the patient, and this patient was already having the one posterior midline surgery, and this was a recurrence, and this was after I think couple of years of recurrence. But you can see that there is a big central herniation, and the canal is also very compromised.
Firaz, please
Yeah.
explain the cross sections little better.
Okay. Okay. Sir, let me just because these are the slides of going on. I will have to switch over
Okay,
to
okay,
my
no problem.
photo.
Yeah, take your own
Yeah.
time.
Yeah. So like see, this is like a no, this is like a normal whenever we need to work on the patient with the alpha S1. I always like to take the AP view of the X-ray, and to see the how big is, how high is iliac crest. And this is like normally this is a very easy case for the suprailiac for the disc work, but especially for this patient, when this patient was having the very big central herniation, uh, I need to show you the picture. Mm, okay, my screen is visible.
Yes.
Hello, sir.
Yes.
This is all is visible.
Yes, it is
Okay, so
visible.
now we can. Okay, now you see this is the L5S1 area, and in the cross section you can see that this is having the left side paracentral and the central herniation. The phlegm is not too big here, but usually if you see this X-ray and the X-ray lateral view, because of the previous surgery also the disc is quite collapsed. So here we have to make the window a little bigger, because even that for this patient doing the surgery will further collapse the disc in future. But if we do a good bone work, and if we make the room for the nerve more better, like what we did for this patient. So so we purposefully did the transiliac approach, and then you can see that we go inside the disc, and then we put the dilator and everything inside. And once we were so flat, and once we were very sure about the area which is very important. So here we have to do some of the bone work, because the disc is quite collapsed, and making the foramen more bigger by using this high speed drill, bendable drill, or you can use the Trifine, or you can use the manual bone drill. It will make the room a little bit bigger, and then you can see that it's easy to take out this herniation. And this was we could remove it in 3 4 pieces. So like this is a case of the stenosis because of disc the disc cause is a major, but there was some lateral decompression was also required. So this was we were discussing that in the classical case of the lateral canal stenosis, what we have to work. And by working only on the phlegm, we are working mainly on the roof. But does it necessary to work on the floor? This is like it can be a debate, and we can always discuss depend upon our experience and result. So I want to put this question to our forum, that whether working on the floor is also this having advantage or not. Thank you.
Okay, very good. I think you
And so
brought.
the yeah,
Yeah.
yeah, and there are more surgical cases. So Bhupesh was supposed to take the surgical cases and pre and post op MRI and something. So I was just going to speak about the outline and the technique. So maybe
Okay.
the next our seminar is about the lower zone surgery. So we will try to work together and make it a little more useful with the pre post MRI and other pictures.
Yep. Okay. So what we will do now is we will just recap the concepts which we have talked about. There are two things to be understood very clearly. Number one, the upper zone is the area which is above, let us say at L4-5, the upper zone is the area which is above the end plate of L4 towards the pedicle of L4, which has the L4 nerve which is exiting with the dorsal root ganglion. And the mid zone is the one between the upper and lower end plate at the disc level, and it is more important to know that mid-zone will have the osteophytes, the changes in the annulus of the disc, the hardening of the annulus, the loss of concavity of the posterior aspect of the disc, calcification of the disc, ossification of the disc as the causes, as to reduce the diameters or the volume of the lumbar canal. In the upper zone, it will be mainly up migration of the superior articular process, hypertrophy of the tissue on the superior articular process, and the ligamentum flavum in the lateral aspect. So these basically are the targets. In addition, I'm going to make one important statement. Please pay attention carefully. You have a loss of normal relation between the lower end plate, that is L4 end plate, and the tip of the SAP of L5. Normally, these two are in the same line, and you will find that it is uh, it is disturbed. It is not the same as it should be. So we need to pay attention to this aspect, that there is a loss of normal relation between the lower end plate of the upper vertebra and the tip of the superior articular process of the lower vertebra. Now we are open for questions, and we can go ahead with questions. So those of you who would like to ask questions or comments or anything else about what we have talked till now are welcome. You can unmute yourself and talk, or you can put in your question in the chat box, which I will take up or I'll ask Shiraz to answer. I also see a lot of my colleagues over here, so I would encourage them to also comment on what we have just talked and ask questions about what they feel is important or what they feel needs to be highlighted, what they feel they have realized in their practice along the lines which we have just mentioned. So let's go ahead. I think,
Sir, I have a question.
yeah, Varun. Okay. Now, please unmute yourself, Varun.
Sorry. In case of a central disc herniation where the component is mostly in the central part, I find that with the true posterolateral approach, like you have taught us, sir, it is becomes sometimes difficult to catch the central fragments, and the patient is not relieved
No, not really. If you use the hook and the curette, you can definitely get the fragment. There's no question.
So how
You
so
can
the
100% get the fragment. You see, the problem is when you say it is difficult or you are unable to get, either you lack the instruments or you lack the visualization. You see, we are within millimeters of the target. So what happens is, I have seen that there is a wrong concept in the mind of many people that when you are trying to address the central part of the posterior annulus, you have to go very flat, which is not true. You do not have to go very flat. You go like usual, go right up to the midline, then start removing the nucleus. Once you remove a little bit of nucleus, the tip of your instrument inside the disc becomes little more mobile, and then you use the facet as a lever, as a fulcrum for the lever, and then you press your scope towards the ground. You can 100% reach the fragment. The problem is, as an idea to go far flat, you stay away from the facet, then you don't have any fulcrum to leverage your cannula and your scope towards the posterior annulus. This happens because sometimes you have not understood the mechanics of that entry and the importance of staying close to the facet. So stay close to the facet, use the facet as a fulcrum, depress your cannula and the scope, you will 100% reach the fragment. There is no question. There is no argument about that. If people tell me that I cannot reach, therefore I think interlaminar is better, therefore I think biportal is necessary, I would agree with it. But then you have to remember that when we talk, we are talking about the technique which is mature, which can be executed exactly like what we talk. When you are talking, probably your exposure to the technique is for a shorter time, so you have not exploited all the power of that technique. So you may have to look into this matter, improve your visualization, probably sit with some spine models and imagine exactly what you are doing, and the importance of staying close to the facet. I cannot overemphasize that point that you must stay close to the facet.
Do we use flexible graspers also in the ventral side for these kind
Sorry,
of?
I didn't hear you well. Say it
So
again, please.
yeah. So do we use flexible kind of graspers which can go towards the ventral side when from the bottom in these kind of cases?
No, as I told you, you see, if we are talking about disc herniation, you have to remember that theoretically the annulus is intact except where there is a herniation. Correct? So, what you do is you use a hook, which is a bendable instrument, put the hook inside the disc and start pressing it against the posterior annulus. Now, what will happen is where the annulus is intact, the hook will remain in. I mean, you won't be able to flex it. Let us say you go little ahead and try to flex it, and it suddenly flexes. It means you have entered the tear, and there you twist it like what we used to call many times a teddy ungli. You put your finger and sort of twist around the fragment and pull it in. In addition, of course, you can be benefited by a flexible grasper or a bendable grasper. But primarily, all this surgery will be much more facilitated if you are able to visualize it better. Now, there's a question from,
Sir, I
yeah,
have one more to add to Dr. Agrawal's question.
yeah.
Is that the best, like, what is the best thing which is going to help is like whenever there is a disc herniation, if it is a central tear and the disc has come out, so always the neck of the herniation, the tear is going to be small and the herniation has gone through that. But the mostly the remaining part, so like it's like a mouse and tail, once you go, so the most important step here in the central herniation is to do a good annulectomy. And once you have the good instrument to do the annulectomy, usually you need a little upbiting kind of annulus cutter. So what will happen that this will do the medialization of the window. Like, so the herniation, we are actually widening the annular tear by doing the iatrogenic annulectomy. So the neck of the herniation will be now more free. And then once you hold, so don't try to attempt to remove something. Just try to do the good annulectomy and just try to mobilize. And then if you hold it and you are trying to pull it out, but if it is not coming, then don't pull it. Let it be there. Do again the good annulectomy and just try to mobilize. And as Sir said, the hook is one of the best instrument for anything which we cannot reach, because this is the bendable instrument. So this will go and then you mobilize the thing, and then once you hold the base of the herniation, it will automatically take out everything with it. So it has to be like we always give the example of a knife. So if we put the knife on somebody's skin, it will not hurt anything. Only it will go in or it will cut the skin if we give the pressure. So this back pressure is always because of not the tip of the herniation. It's always because of the some more material, some more the base of the fragment which is inside the disc, and that is pushing the neurological structure, and that is the reason for all the neurological symptoms. So wide annulectomy is one of the very good key to do the medialization of the window, and you can make out the annular tear bigger, so the neck will be now more free, and the herniation will come out. And again, don't try to pull it out if you are not able to take it out easily. Otherwise, you will break the herniation and the tip which is there inside the canal. Then it will be a very difficult job to take out the tip of the herniation. So that is one of the very important trick for the central herniation, or even the herniation which is inside the canal. There always has to be some thing inside, and you just have to hold the tail, make the window bigger, So the entire mouse will come out.
Okay, there's a question
Dr.
by our friend Dr. Manoj. He's asking, what exactly do we do for lateral resistenosis? Do we concentrate on the floor or the roof? How do we safely remove the ligament in this particular location? The answer is, first of all, we have to be very clear about what do we mean by lateral resistenosis. Lateral resistenosis is the lower zone stenosis according to our new nomenclature, where this area of the stenosis is below the lower end plate up to the mid cross pedicle line, or in the coronal plane, in the AP plane. This is the area between the lower end plate and mid part of the pedicle, closer to the tip of the inferior articular process. Number two, what is the tissue which gives stenosis in this area? The tissue is not the posterior midline ligamentum flavum, but the tissue is the cover of the facet joint and the hypertrophic tissue in that area. There are two ways of looking at it. Some of us are definitely able to take the ligamentum flavum right up to the midline. But for practical purposes, if you do a lower zone decompression by doing an oblique pediculectomy, it is fine. So that would be the answer. More about that we will be talking in the next webinar. The landing of the needle, should it be different in different zones? Is a question by Dr. Amit Mukherjee. Absolutely, yes. I will quickly tell you what it should be. In case of upper zone, the needle initially should land at the upper end plate of the disc, so that when you land there, you quickly turn your cannula towards the head and you work on the roof with the curette or the flexible drill or laser or RF. If you're dealing with a mid zone where you may prefer to work on the posterior annulus or the undersurface of the facet, you land in the middle part of the disc. And for the lower zone, you start from above and land towards the lower end plate or the lower notch of the vertebral foramen. I think that clarifies the matter. Yes, the answer is yes, that for three different zones, three different angulations, trajectories would be necessary. And this is what I was referring to, that please kindly visualize it more before actually doing the surgery. Now, I would prefer some comments from some of our colleagues about what we have just talked, so that we also know that what is their experience vis-a-vis what we are talking. So either we have volunteers or we have some requests, so that please unmute yourself and you can talk. Okay, suddenly there is extreme quiet, so I would now request some of my colleagues to have their opinions. Dr. Manoj Sharma, why don't you give your experience about lateral resistenosis by your preferred method of treatment? Dr. Manoj. Yeah, I'm just unmuting you, Manoj, so that you can... Oh, sorry. I'm unmuting you again. Yeah,
Hi,
you're
Doctor.
unmuted. Okay.
So great. It was an excellent talk today. And I was actually thinking, it means that the middle zone, what you have just talked about, is the zone of the disc. So you want to say that in this zone, the only cause would be an extruded disc? Because I
No,
thought I
I'm
had...
not talking about extruded disc. I'm talking about the disc which is not herniated, but
Yeah.
there is a change in the annulus in the form of
No,
osteochondrosis.
I
Yeah.
had always thought that in the foraminal stenosis, either you have got a stenosis of your exiting root, for which we had a talk last time, or you have got a stenosis in the lateral recess of the traversing root. Now, the lateral recess, you have said you will be talking in the next meeting.
Yeah. Yeah.
So I was thinking that lateral recess begins at the level, because the root comes out at the level of the disc. So the lateral recess starts where the root actually comes out. So it comes out at the level of the disc. So I thought maybe the lateral recess starts at the level of the disc, and then it goes down right till the root comes out distal to the distal pedicle. So that is why I said that how, I mean, in this, because, most of the time, how we decide about stenosis in MRI is most of the cut are at the level of the disc. So we see at axial sections, we see, and we decide that there's a foraminal stenosis, or else the parasite sections can tell us about the exiting route. But about the traversing route, we mostly talk about by seeing the
No,
cuts
no,
at the level of
Manoj,
the disc.
you're mixing issues. I will tell you. We have already talked about 4 cuts which
Yeah,
are taken in every cross section in the MRI. The first cut is at the lower border of the pedicle. The second cut is at the lower border of the upper body. The
yeah.
third cut is at the lower border of the
Mm,
disc. And the
mm.
fourth cut is at the horizontal midline of the pedicle. You
Yeah,
may
so
take
in
a
the
fifth
future, we will
cut.
have to ask people. In the future, it means we will have to ask the MRI
No,
centers
no, no.
to
Every
get this
MRI
kind of
person
cuts.
gives these 4 cuts.
No,
Each
they
and
mostly
every
give cut
MRI
at the level of
always
disc.
comes with these 4 cuts. All of
No,
them.
axial cut I'm talking. Axial mostly they do at the level of disc. Anyway, it's okay. Yeah.
No, no. My point is these are distinct cuts. There is no confusion. And the lateral recess, as per the old description, is like this, that if you're talking about lateral recess stenosis, then the lateral recess begins at the lower border of the disc, for example, L4-5 for the
Mhm.
L5 root. And
Yeah.
then the root goes around the pedicle and then it goes out. So the lateral
Mm.
recess is supposed to have 3 zones: the entry zone, the mid zone, and the exit zone. So what you said is correct. It has got these 3 zones. For us, we feel that the lateral recess mid zone and the lateral recess exit zone has nothing to do with stenosis because the bone in that area does not change. The only change can occur in the entry zone. For example, for L5 root, this entry zone change will be at L4-5 disc. The lateral recess change for S1 root will be at the lower border of L5-S1. So we are not
Mhm.
confused. We are extremely clear about what we are
Yeah.
talking and where we land. Problem is many times we are in our mind having a different image but
Mm.
using a different word.
Yeah.
So sometimes it becomes confusing.
Yeah.
And in case of lateral stenosis or lateral recess stenosis, I would say I would talk more about which root is involved. So if you tell
Mm.
me that the symptoms are because of L5 root in case
Yeah.
of stenosis, I know that the L5 root can be involved in the lower portion of L4-5 or it can be involved in the middle portion of L5-S1. These are the two
Yeah.
areas. I'm sorry, the upper portion of L5-S1 and the lower portion of L4-5. Theoretically, I can work at both areas. When the root is
Mm.
involved in the exiting position in the upper portion, the main cause is in the roof of the foramen.
Mhm.
The
Yeah.
ligamentum flavum, the lateral ligamentum flavum, which is between the tip of the SAP and the pedicle above. Now,
Yeah.
there is a comment
No,
by,
no,
yeah,
there's one
sorry,
more thing. There's
yeah,
one more small thing.
yeah,
That is that at the level of the disc, also, we will have some osteophytes on the medial side, which might compress the root as well, the origin of the root. So, I mean, that's what I'm saying, that at the level of the disc, because the disc is the most mobile thing. The rest of the body will not move, and the SAP also moves up because the disk space becomes less. So it is because the disk, the whole thing is happening. So and that is why we do the medial facetectomy at the level of the disk in order to take care of the lateral recess. So that's why I'm saying that lateral recess for at the level of the disc, should we remove the medial osteophytes of the SAP? I mean, that's my question.
No, I was not very clear what you mentioned. I would say that the osteophytes are almost always paracentral.
Mhm. Okay.
Almost always. That is at the upper end plate or lower end plate. And I agree that if you're talking about lateral recess, it will be the lower end plate and it will be the lower zone. It will be below the disc level where the root, as it goes out and comes out of the lower foramen, will be involved.
Right. Thank you.
Okay. Yeah, thanks.
Thanks
There's a
very much.
question by Dr. Praneeth Singh. Need I be doing annuloplasty simultaneously? Can you please repeat the axilla, extend, and the three zones? Okay, there are three zones. If you're looking at one level, that is L4-5, the upper zone is lower border of L4 pedicle to the lower border of L4 body. That is the upper zone. The middle zone is the disc, that is between the two end plates. And the lower zone is the lower end plate at L4-5, that is the upper end plate of L5 up to the mid pedicle cross section. So these are three zones. The axilla naturally is in the upper zone, and there is a need for annuloplasty. No, annuloplasty apparently has no role to play here. Theoretically, if you are using the word annuloplasty as a matter of repair of the annulus after working on the annular tear, then yes, you do annuloplasty. But for stenosis, we are not doing a annuloplasty. Then there was a comment by Dr. Pal as having the right instrument for the purpose and its intended use is very crucial to avoid failure of the procedure. Absolutely. I would again emphasize the same point, which you have very properly mentioned, Dr. Pal, that you see, please remember, we have developed our philosophy based on years of experience. This is not a fashion or this is not somebody's whim. This is science. We have based our observation on thousands of patients, and then we have developed our philosophy. This philosophy then is extended into certain instruments, and those instruments then help you achieve what we start as a matter of objective of the surgery. If somebody is unable to achieve, instead of saying that I do not know how to do it, most of the times the human tendency is to say that this technique is bad, or the instrument is incorrect, or the instrument is not designed properly. This is insulting to the intelligence of the person who has developed it. But it is very, very common to see these sort of comments when surgeons are interacting with each other. I have never ever heard a single surgeon in my life till today, in last 37 years of practice, that the surgeon would say, I am wrong. I don't know this. I cannot do it properly. Instead of that, many would blame the instrument, or many would blame the lack of clarity on the technique being bad. This is not correct. Why we are holding this webinar in such a detailed manner is mainly to make you aware that there is a deep thought behind all these things. So we interact on that, we pick it up so that we are more effective. Now, what do you exactly mean by annuloplasty? Okay, there was a time when we used to feel that the annulus is deficient, especially at the area where it is torn. I mean, the original torn area of annulus, which is symptomatic, and we have to repair the annulus. In those days, the only repair which was possible was by heating the annulus by RF probe. That used to be called as annuloplasty. Some people used to do laser assisted annuloplasty. That is heating the annulus so that the protein, the collagen in the annulus will denature, it will shrink and sort of close the tear. But it never used to close completely, number one. And number two, the mechanical properties of that area never, ever used to recover. That is why we came out with a biological solution for the annular repair, that is our Derwent plug, which is a platelet rich fibrin plug. This is mechanically strong. It is picked up or it is assimilated by the annulus properly, and you can have a good healing of the annulus. You can also have good strength of the annulus over a period of time, maybe 6 months to a year. Some more things will happen around annular repair technology very soon. In the meantime, we are happy using the platelet rich fibrin plug. Now, I was seeing Dr. Ihab somewhere. If he is here, Dr. Ihab, I would like you to comment. In the meantime, I will take up this question from Dr. Vinod Jagtap. He is saying in the early days of practice, we don't have all these flexible burr or high speed burr. Can it possible using manual trifine and use of cutters, curettes, RF, which we usually get initially? Any demonstration possible by faculty in future? Yeah, what you say is correct. There are two issues here. If you don't have all the instruments, naturally, the indications for surgery for you at your level will be little different. You should not go in for very complicated stenosis because in absence of good instruments, you may not be effective. And number two, what you said is, yes, you can work on those cases in a limited way with the burr, with the flexible burr, with the curette, with bendable instruments, etc. And the new RF, which has now come in the country very soon, within probably next, probably about a month and a half, we should be able to talk about the new RF, which can be used for that. Now, there is a question, Praneet Singh, axilla for L4 will be near the L4 pedicle. Correct, absolutely. At L4 pedicle, you have the L4 root going out below the pedicle. It comes on the medial wall of pedicle and inferior wall of pedicle. There's a groove there. And the L5 nerve will be going down towards the L5 pedicle, which will come out of the L5S1 foramen. So what you said is correct. That's right. Now, I didn't see Dr. Ehab. He was here. I don't know. Probably he might have left in a hurry. And okay, there's a question by Dr. There's a mention by Dr. Ankit Madaria. I have been cutting the annulus up to midline in cases of mid-zone stenosis and removing the annulus to decompress the dura. Is it routinely done or I am overkilling it? The answer is both. I mean, you are overkilling it if you're doing it for every patient, but is it routinely done for the patients where you have a hardened annulus? You see, there are two issues there about this annulectomy being done right up to midline. The issue is most of the people do it to see the traversing nerve and to visualize the traversing nerve better. So doing it that way is okay, but commonly, if you're doing it in an elderly patient, then you incur a likelihood of iatrogenic instability over a period of time. And then you must use adequate annular repair. And it is overkill in that sense. But if you're treating hardened annulus and if the annulus has straightened, there's a loss of concavity of the disc in that area, that is say L4-5 commonly, the posterior concavity of the disc is lost, then doing an annulectomy, which will decompress the traversing nerve, is definitely indicated. So you have to do. Now, I'll take one more question and I'll ask Shiraz to give a comment on that annulectomy. There is a problem with Carl Storch. They always cry about less sale, but never respond back, are always deficient of all the instruments. They have very limited inventory. All this is false. I do not agree. Everything is available every day, every time. You can call them now and they will supply you immediately. Flexible burr are not available with Carl Storch. That is correct. We have flexible curettes. So you can use the curettes, which goes through our scope of 3.6 to 5 working channel. Indian companies do not make a flexible burr. Indian company makes a battery operated low speed drill machine. It works at 525 RPM, costs about 1 lakh rupees. Storage more responsible and dynamic and proactive. That's not my responsibility. And I do not agree with you, Manoj. I do not agree on that point that they cry, less sell, and they don't respond back. No, I don't think so. You can again message them. I'm sure they will respond. If they have not responded, what you could do is when you mail them, make a CC for me. Yeah, there is somebody who has raised his hand. Ankit Mukherjee. Yeah, please. I don't know. There are some sounds coming in, but I don't see who is. Hello. Hello. Okay. So, Shiraz, you go ahead with your comments on annulectomy. I'm unmuting you.
So, so sir, basically, we have to make all of us very clear that classical technique, what we used to we are doing currently, is an inside-out technique, and people have a different concept that if it is a central herniation or the herniation is in the canal.
No, they don't have any concept. They interpret in their own way. They have no concept. They do not read. They do not pay attention to the details of the technique written. I mean, we have published enough. If you read properly, each and every word has been thought about and written very properly. Everyone tries to have his or her own interpretation, which is not science. You cannot interact on such basis where you have your interpretation of what somebody has said. I mean, I understand that naturally you will have an interpretation, but practically it should not be like that. Yeah, go ahead. Sorry.
Yeah. So, sir, this is a very important point, because the safety, what is associated with the inside-out technique, going inside the disc, you are very safe because you are inside the disc, and the annulus will anchor. It will hold your scope, so the scope is not floating. And since so there is a big group of endoscopic transfemoral surgeon, especially in the Southeast Asian countries, they believe to go within the line of the herniation, and then only they want to take out the bulge, which is absolutely
that
not.
is simply because they hate my hook. They do not want to utter that word HOOK. I mean, it is their problem. They can't work like that. It doesn't mean anything. You see, what has happened is we have been keeping quiet about this nonsense for a long time. It is not correct. Science is science. Don't bring your personalities in that. Okay, scientific development is scientific development. Whether you like my face or not is another question. You cannot keep your patient away from the benefits of developments just because some bloody fellow says that no, I will not use. I don't like it. I mean, you can't do that.
No, but sir,
It's okay.
I tell you that this has created a big confusion, because see what is the inside out technique, and with this technique it is so safe, and like otherwise, sir, if you see the most of the big shot transfemoral surgeon, they have made this surgery so complicated by using the laser and so many complicated instruments, and then the people who is ready to learn or he is going for the training, they will see and say, oh, laser, oh my God, 10 million, oh my God, no, it's not something for us. So what happens that this is making the surgery economically not viable. But like sir, very simple, going inside the disc and doing the good aneuploidy, you can take out any kind of herniation, and the most important is safety. So like even for the annuloplasty, there are so many commercial things which have started available. But if you see that if we use the plug, so definitely the plug is in the gel form. Once we take out the herniation, and anywhere if there is any herniation, the disc has come out. So that part of the disc which has come out below the posterior annulus, it will be little empty. So that part, if you do the discectomy, you take out the herniation and then you put the gel of the L1 plug. So that will going to occupy the space, and that has a very good sealing effect. And hardly it's costing 10 or 15 rupees. So that way, that going inside out, doing the inside out technique, and without understanding the concept, uh, by going flat, the people are having the complication like the nerve root injury and the dural tear and a lot of bleeding, and then ultimately it creates the bad name to the technique. So it's very
No, it
very
doesn't create bad name to the technique. It only shows your idiocy. It only shows your immaturity. It
yeah
only shows you are just trying to show off. It
yeah
shows your lack of understanding. I mean, how can the technique be bad mouthed if you don't
and
even
sir,
understand what the technique is? I'll tell you one recent joke. I met somebody from a big city, from a big hospital, and he said, "Oh, hello, sir. So you do inside out, right?" So I said, "What do you do?" He said, "No, I was thinking I would do outside in." So I said, "I do inside in, I do inside out, I do outside outside, I do inside inside." I mean, there's no point in talking with such people. Our time need not be wasted on that. So we'll come back to our questions. Please go ahead, unmute yourself and ask your questions, or otherwise put it in the chat window. And for the sake of information, I've sent 3 more papers in the chat window. 2 are by Dr. Sota Omoji, who is a Nigerian, as I recently came to know. I was not knowing, I thought he was a Japanese. And the good thing about him is I was told by a friend from Nigeria that he has also written their national anthem. He's a co-author of their national anthem. So very big man socially, politically, and of course, scientifically. I also sent 2 more books. One is by Dr. Robin Mackenzie about mechanical disc treatment that is mainly based on his exercises. And there's one more by Nikolai Bogduk on clinical anatomy. I would say that if you want to be good as endoscopic surgeon for stenosis, you must have an extremely clear understanding of the anatomy. You cannot bluff your way. You cannot use terms which have no meaning, and you cannot mix up terms, because in anatomy, pedicle is pedicle. Pedicle is not spinous process. Pedicle is not transverse process. Pedicle is not superior articular process. Pedicle is not pars interarticularis. So we need to have a very, very clear understanding of the anatomy. And secondly, as you rightly mentioned, Shiraz, that if we want to make our surgery extremely safe, you must appreciate the first fundamental of transforaminal endoscopy, that is Cambin's triangle or safe triangle in a patient who is awake and aware. Another problem I will tell you. Now, there is a problem in the mind of people that Cambin's triangle is only the floor. It is not true. Cambin, in his book, has described Cambin's triangle not as triangle, but it is also inclusive of the superior articular process. So we should start calling it as Cambin's pyramid or Cambin's cone, which includes the posterior wall. The main thing which Dr. Cambin proposed is there are 2 live nerves and there is bone at the base of the triangle. That is why it is safe. And if we realize that we go through the triangle, it will remain the most safe spine surgery. Otherwise, it will always be carrying on with the same complications which we used to have in the past, including the failed back surgery syndrome. So that's what it is.
And
Okay.
sir, one most important thing I want to add here, that in the mid-zone surgery,
रमेश तू वेंच गया
if you don't remove the facet,
बनने माने ओमने फोन करू अच्छा पेशेंट के
hello,
Yeah, go ahead.
yeah. So in the mid-zone stenosis surgery, if you don't drill the facet, if you don't drill the superior articular process, you will not be able to find out the ligamentum flavum. Once you drill it enough, and once you drill it in on the upper side, lower side, then you will be able to see the flavum behind that part. So because the flavum here is more medial to the facet joint, so that is something you need this. Otherwise, you will end up with just doing some decompression, foraminal decompression, and the disc surgery or disc discectomy, but you will not be able to touch the flavum. So ultimately, your post-operative MRI will always remain same. The patient will always have the same similar symptoms. So here, this is very important that when you are touching this, we have to have the very clear understanding, and that's why the anatomy of the ligamentum flavum, which is taught to us by Gore sir, is something extremely important. Otherwise, we just used to see only the central flavum, the V. That's all. But now that if you see in the lower part of the foramen, you see the flavum is much more hypertrophy because it's having the lower attachment. So, and usually that is going to compress more of the traversing route rather than the exiting route. And relieving this traversing route by going oblique toward the lower end plate. And even if you select the same approach, what we used to do for the disc, so you have a very safe entry, you are not worried. And actually the cannula and the dilator, it will keep on compressing the vasculature, so there will be no much of the bleeding. And then once you start gradually coming out, so that visualization and that decompression and having the very particular instrument, that is the key of the surgery. Otherwise, we will see a 30-degree angle. So even right now, we are thinking to bring around 15-degree scope, and we just want to see that what is the difference with the 15-degree scope, that how the structure look different. So that will give us the more idea about that how this will help or not. So understanding anatomy and having the very, very clear understanding of the anatomy, because this is not the same midline anatomy. This is everything is from the side. And again, one most important thing is that in stenosis surgery, especially those patients who are only symptomatic in the standing and walking position, we are just relieving the vascular congestion. So even if the patients are not very much symptomatic on the other side, if you do the good decompression on the one side, that is also enough to relieve the congestion, and the patient will also benefit on the other side also. So this is the one of the key point that we have to understand, because we have the enough experience that we see the similar kind of MRI, similar kind of patient, but they have a different presentation. So here, finding out the patient who is having the more symptomatic, and if you can match with the clinical examination and the MRI, in which you can see there is a more left lateral canal stenosis, and if you do the very good, and patient may have the mild symptoms on the right side, still, like we don't need to attempt both at a time. We just need to go do it with the one side, and still this relieving of the vascular congestion, it will definitely improve the patient other side symptoms, and usually the patient do very well.
Yeah. Now, there is a question by Dr. Ankit, who has recently started doing endoscopy, and he is courageous enough to start endoscopic stenosis also. He's saying that since the time I have started doing stenosis surgery, I have broken curettes, grasper, and hook, and it is looking a costly affair. Any tips to prevent the loss? Yes. The
So
simple tip. Yeah.
let me answer. Let me answer.
Yeah.
It's a
Yeah.
very answer. So normally, this was a similar situation with every the beginner, every starter. When so what happens are actually that when we are working, so if we are not able to hold the structure, so usually the instruments are strong enough that whenever we are working, the instrument is having some torque. So sometimes we are not able to hold something or something, and then automatically our pressure goes here. And that's why so once you close the jaw and over that, if you press it more, there is no further advantage. So definitely, if we are very careful that once we are working and we are not able to hold something or we are not able to get something, so we should not apply this pressure on the hand, because this will never work. So again, see, when in stenosis, you must have the see, normal the grasper, they hold like this or hold like this. But when you are working on the roof, so you should have something which is holding up. So this up biting the grasper, that will definitely ease your work. Otherwise, those jaws, they are open, but then they will not be able to work on the roof nicely. So that way, the most important thing is to have the proper instrument. And if you apply the wrong instrument to do something extra, then definitely you will have to open it more, or you have to press little hard. So that is something we have to be very clear that using the proper instrument, it will do its own job. So like this up biting grasper, it will hold the phlegm nicely on the roof. But for the disc, again, the same thing will not work, because you have to go more straight. So usually I see that this is when we are having troubling, or when we are fumbling, we try to put more pressure on our hands, and that usually breaks the instrument.
My comment on that is, number one, the main thing which nobody can teach you is the hardness or softness or the texture of the tissue from outside. It is only when you feel it. Now, feeling this in case of transfemoral endoscopy again is very difficult, because the tissue which you are going to feel is much away from you, almost 15 to 20 centimeters away from you, and you are using the instrument to probe and feel. So this is one difficulty which will only be overcome as the time passes, as you do more and more surgeries. The second difficulty is, if you do not read your images properly, you will be still in more difficulty, because the images can give you some indication about the hardness of the tissue, about the tissue being soft, firm, hard, bony hard, stony hard, etc. The second thing is, instruments always break for the beginner, mainly because, as you rightly pointed out, beginner is trying to be very aggressive without knowing really what he is doing, and then the instrument hinge will bear the brunt of his force, and the instrument will break. It will always be at the hinge. The third thing, which is a very simple point, which I'm just going to mention here, if we look at various graspers which we have, there are two things which are there at the working end, the surgeon end of the instrument, right? There are two, what do we say, two parts of the instrument at the surgeon end. Commonly, you will find there are some instrument makers who will keep the surgeon side thing stationary, and this arm will move. I hope you get what I'm saying. There are two things. In some, this will be stationary and this will move, and in some, this will be stationary and this will move. Now try these instruments and you will find that the one towards you should be stationary, because ergonomically that is much more easy to use and not break it. So these are the tips. In addition, of course, the tip is keep one spare instrument, especially the black grasper, because that is the workhorse in your surgery, where you need it every time when you're doing the surgery. Now I would request Dr. Girish to give his comments, since, yeah.
Yeah, sir. Thank you, sir. Sir, Dr. Ankit is asking the question, and you as well, Dr. Siraj, mentioned all well. Though I was beginner 2.5 years back, and I broken, I think, 10 hooks, Dr. Gore's hook in a year. And from last 1.5 years, I never broke a single hook. And I would mention here that because in initial we are the conventional surgeon, and according to the conventional surgeon, we use the force by hand. So same habit convert to over the endoscopic surgeries. So to Dr. Ankit, I would mention here that this is a very cheap affair to enter in the heaven of spine, because I think it's not so costly affair to enter so much precise surgeries. And sir, second thing, I would also add a comment that it means whatever we are discussing from last 6 webinars, it means that the pathology of the lumbar canal stenosis are on the different zones, but the symptoms more or less are the common. Either the pathology is anywhere in the upper zone or the mid zone or the lower zone. So what are the conventional surgeons are doing? They directly or indirectly operating the all 3 zones unnecessarily, while we are dealing the one single zone where the pathology is. So definitely the transforaminal surgeries are the very precise surgery, and we are dealing the single pathology directly over the pathological zone. So definitely the transforaminal surgery are a very fine and the precise surgery. So I would mention this for the all audience and the delegates who are attending our webinars continuously and very sincerely. So definitely it's a good survey, good technique to enter in the heaven of spine. Thank you, sir.
Yeah, on that count, I would say that for a traditional surgeon, many decisions are taken during surgery after they observe the target and then do or then decide what to do. For an endoscopic surgeon, all our decisions in general are taken before surgery. We prepare for the surgery for a long time and execute the surgery in a short time. What I mean is, if I am looking at L5 stenosis, then I know that I may have to work in the lower zone of 4-5 or in the upper zone of L5S1, like that. So I do agree. Now, there is another mention or a question and comment by Dr. Praneet Singh. In case of endoscopic discectomy, does it depend on the type of herniation to go for inside out or outside in technique? Now that Bhupesh, you have joined, I wish you take the question and then you also add your other comments on the topic. I'm
Yeah,
unmuting. Okay, you are unmuted. Fine.
yeah.
Go ahead.
Good evening,
Shall I
everybody.
repeat
Good
the
evening, sir.
question?
Yeah, yes, sir. I think you should repeat.
Yeah, the question is, in case of endoscopic discectomy, does it depend on the type of herniation, whether you do inside out or outside in?
Yeah, for the beginner, or I can say 95 or 98% disc herniation we can do with inside out technique. Most of the herniation, if it is very high grade down migrated herniation or up migrated herniation, we may need to stay epidural. But most of the herniation we can deal with the transforaminal inside out technique, because in once you are inside the disc, you are very safe. For outside in technique is not safe for beginner, especially for always advanced learner. It's not safe. If you go inside the disc, then your orientation is very much better than outside in. And outside in, the lots of bleeding happens, and then you may lost in somewhere, and there is high chance of neural injury with outside in. So I can say for everyone, inside out is safe, and we should attempt inside out only.
Yeah. Now, the next part which I asked you is you give your comment on mid-zone stenosis surgery as a concept. I mean, um, you can always present more cases, MRIs and data next time in the lower zone
Yeah.
surgery. But today
Okay.
you can give your comments on mid-zone surgery. What does it mean to you and what is important in that?
Yeah, the mid-zone surgery mainly we have to decompress the discal part. Many times the disc is a disc herniation, acute disc herniation, followed by if check untreated, then it may become chronic collagenized annulus and disc fragment, fibrocartilage fragment, and it may become calcified. So it gives rise to the stenosis. So in the mid-zone stenosis, the main part is disc. Second is lateral recess. The phlegm which is in the lateral recess, we have to address the lateral recess also. So here is foraminoplasty is the main part for mid-zone stenosis. So we have to remove the superior articular process in order to see the ligamentum phlegm in the lateral recess, and the disc part which is hard and collagenized with along with the annulus. So foraminoplasty is the main part. Second thing is the osteophyte which are in the superior end plate or inferior end plate. We have to address, and other is a hypertrophied facet capsules and ligaments surrounding the facet. So all these part we need to address for a mid-zone stenosis. So begin with the disc herniation. If disc is hard collagenized, you can have articulated instruments, curate. I think the side bendable curate, which is there in Karl Strozzi, Dr. Goris said. And the second thing, annular cutter. Many times, if disc is very hard, annulus is collagenized, then we have to cut with the annulus cutter, and it will not grasp with a normal grasper. And third is end plate osteophyte. End plate osteophyte, many times we have to use the burr, high speed burr or whatever, a small. Nowadays there is a orthopedic drill is also available. So we have to burr that osteophyte also to completely decompress the traversing nerve root. Here, mid-zone stenosis is mainly to decompress the traversing nerve root. And if you can see free-floating traversing nerve root in the lateral recess, then your decompression part is almost finished. Many times you may need not to go to the opposite side, because as Dr. Siraj has mentioned, there is lots of vascular phenomenon is happening in the lumbar canal stenosis. So once you are just decompressed, the epidural blood flow started in that zone, and almost the neovascularis and vascular remodeling and restructuring is going on. So at that time, many times your contralateral symptom is also taken care of.
Yeah, perfect. Now, there is a question for you, Bhupesh, because you have joined now. So I would bombard you with the questions.
Yes, sir.
Question is, I have one patient right now in front of me. 70-year male, had back pain radiating to right hip, thigh, uh, calf muscle. EXT patient has right thigh pain, vertical pain, sign positive on the right side. Okay. This is a question by Dr. But he hasn't asked question. He's just mentioning. Amit Mukherjee. What will you do for this patient? Right-sided static pain, mainly in the back, the thigh, and the calf, and the hip. And my sign is positive on the right side, and the pain
So,
is vertical.
yeah.
In the back.
So that means most likely it is from L4, L4, L5 or L4, L5S1, lower lumbar segment, and it's a right-sided pain. So first, if the back extension of the back is relieve his pain, then we can treat conservative with medication, gabapentin or pregabalin, and some anti-inflammatory, especially etoricoxib, which is selective, which is TNF alpha inhibitor initially, and we ask him to do back extension exercise. If it is not relieved this thing, we have to go for the imaging study, mainly the MRI of lumbar spine and X-ray, with dynamic X-ray of the lumbar spine, which may need to see whether it's a stability of lumbar spine is there or not. And if MRI suggests something, then we have to tackle accordingly. Is there MRIs available with this patient?
Dr. Mukherjee is asking me, how do I send the images? So I just told him that on the right side there's a facility to send the file.
Sure.
Or otherwise, the best way, Dr. Amit, would be for you to show us,
Yeah,
as you are
sir. I
now
will show
being
you, sir.
seen. So just give
Yeah.
us a minute.
Yeah, good evening, everybody.
Yeah, good evening.
Sir, I am showing the images. Okay.
Yeah, please.
Yeah, 1 minute. Now you can see.
No, not really.
Your image is stagnant. I think it's not moving.
No, sir. It's not moving.
No. You are showing means you are showing on what? X-ray viewer?
MRI. I am showing the MRI, sir.
Yeah, but then your camera has to be properly positioned. Maybe you need to use the selfie camera. Maybe just try and experiment with that selfie camera or the the back camera. What we are seeing is only a black screen at present.
Okay, 1 minute. Now you can see. Yeah. Now my video is sharing.
So we are able to see your screen, but there is
Okay.
nothing on the screen. It's all black. You describe to us. It's okay. I mean, if it is difficult to show, you describe to us. We
Sir,
believe you.
now Amit sir can share. He has to refresh. Amit sir, can you? Amit Mukherjee sir, right?
Yeah.
Sir, can you
Yeah,
please
now
share
you
now?
try.
I have refreshed the account.
Okay. Now you can see.
No, it is saying your network bandwidth is low, so probably it will either take time if it is a big image, or we wait for a few minutes and see.
You can see, sir.
No, I'm not able to see.
Uh,
You can
while
describe in the meantime.
Yes, sir, there is actually some cystic lesion on the L45 exiting root side,
Okay.
and it is strange for me whether it is something physical cyst or synovial cyst or some schwannoma, I don't know. Okay. It is more in the mid zone. It is almost upper zone is free, and going down in the lower zone also.
Okay.
So it must be facet cyst or discal cyst. So it continuity with the disc, or is there some separate with the facet?
Yeah, it is seems to be that image. That image is not actually there. There is a missing image between. There are two images are missing in between, so I cannot. Guru sir, can I send to your mobile these images?
Yeah, send to my mobile. Maybe send it on WhatsApp. I can take it
Uh,
immediately on the screen.
yeah, I will sending you,
Not
sir.
an
This is a
issue.
very
Send it on
actually
WhatsApp.
very interesting case actually. That's why I want to share with
No
all of
problem.
you.
Send it on WhatsApp to my
Yeah, I
mail.
am sending, sir. I am sending. Just I am
Yeah,
sending.
please. Yes.
Yeah.
So let's wait for a minute. He's sending it. Okay, some images have come. Let me just check and show. Okay, yeah, one image has come. You want to
Yeah, I
you
am
want to
showing
have the
another
opinion
also.
on this
Yeah,
image or the other? Yeah, this seems
yeah,
to
I
be
am.
facet cyst.
Yeah,
This is a facet cyst. I'll just put it there.
yeah.
Let me just put it there. Just give me a
Okay,
moment. Upesh, it is a facet cyst, and
okay.
Okay.
yeah, just give me a moment. I'm putting it there.
I am also sharing this sagittal image also, sir.
Um, no, this main image is okay. The second image also is okay. So let's do that, and I would show it on the screen. Just give me one more moment. Okay, that's very interesting. And okay, what I'll do is I think I'll share the screen with the
Screen,
WhatsApp
yeah.
images so that you will be able to, all of you will be able to see that. Yeah, okay, it's here. Okay, are you able to see the image which Dr. Amit has sent?
Yeah. Yeah,
Now,
we
this
can see.
image shows there is something in the mid zone just behind the body of probably behind the disc of L45, and this is a little misleading only in one view.
Yeah.
So we will go for the other image. Now this is an image where it seems to be, not very sure, seems to be in continuation with the facet joint here, and this is exactly in the lateral recess on the right side. And here what you could do is you could put a needle in this facet joint and
Okay,
do
sir.
an arthrogram. If the dye leaks in that swelling or the
Okay.
cyst, it is a confirmation. But this is more or less confirmation. You can see it here.
Yeah, it's
This
continued
is a
with the
facet
facet.
cyst.
Yeah.
I, for one, if you ask me what I'll do, I will go
Yeah.
through the facet and do a transfacet removal of this cyst. You
Okay.
can also do it by endoscopy, where you go in the lower zone in this case, because I will again show the other image. Just let me have a moment. Yeah. Now you have shown some further images, so I'm just showing them again. So here you will find this is where it is. There's a disc herniation. There's a bulge there, and then we have, okay, here probably, well, this seems to be same image. I mean, there is no different detail seen in this image. So we'll go back to this image, which is showing the thing very well in the sagittal section, and this image which is showing it very well in the first section. So let's have a short sort of poll. How many of you feel that this is a facet cyst?
I think this is a facet cyst because it continued with the facet joint in the upper section. Yeah.
I agree. And what is your treatment? What is your mode of
So you rightly mentioned, but even I think I can do with foraminoplasty. I first do foraminoplasty. I just remove the non-articular part of superior articular process till the lower zone. Till lower zone, I expose the cyst along with that facet capsule, and we with the RF ablation and we can burst that cyst and we remove that nuclear content with RF ablation. We can entirely ablate that part of the facet capsule and that cystic part.
Okay.
This is what I think.
Hello.
Yeah, there is a question. Okay, Amit, did it satisfy your queries? Dr. Amit. Dr. Amit Mukherjee, did it satisfy your query?
So, sir, we have to go for surgery or we have another option also?
No,
Another
we have to go
option
for surgery.
Yeah, the older non-surgical option is there are some people who believe in going in the cyst and injecting it with steroid, hoping that the inflammation would settle. But this will have to be done going through the joint probably after doing arthrogram. The second is there is a mention in the literature where you put a needle in that cyst and burst it by pushing normal saline in it so that the wall bursts open and all the inflammatory cytokines are coming out. You wash them away, etc. So injection. Now there is an important comment by Dr. Paul. He is mentioning that there is a risk mentioned of damaging the genitofemoral nerve at L4-5 disc herniation during tubular surgery as well as transforaminal approach. Could you please opine? Yeah, first, Bhupesh, what is your comment? Later on, I will talk about it.
Sir, I'm not aware about the tubular surgery with damage to the genitofemoral unless we are too anterior during the access. But in transforaminal, yeah, if someone do far lateral approach and some go transpsoas or sometimes go anterior to the transverse process, then there is a chance of damage to the psoas nerves now inside the psoas muscles and probably genitofemoral nerve. For that, we have to strictly follow not to go beyond that angle of your back. So you should stay in, anterior to the transverse process, intertransverse ligament and transverse process. So there is almost null chances, and if you are not confident about your trajectory, then you can also use the CT scan to guide your trajectory. So you are not too anterior to the intertransverse membrane.
Okay, my answer is a little simpler. The answer is that genitofemoral nerve arises from the upper lumbar nerve roots. It's not a branch of the sciatic nerve. And in the upper lumbar area, all the nerves are very, very close to the ventral aspect of the foramen. Below L3, normally all the plexus goes quite away from the foramen, and the distance between the the ventral border of the foramen and the plexus in the upper lumbar could be less than 5 mm. In the lower lumbar could be more than 7 or 8 mm. So injury to genitofemoral at L4-5 is unknown. I have never seen. I mean, I have not even read in the literature, even though I have read it when people talk of, as you rightly mentioned, Bhupesh, about direct lateral approach or transverse approach, or nowadays they have a fashion called a D-leaf, direct lateral interbody fusion or whatever. So in those cases, femoral nerve is very well known to be injured. In fact, that is why they have a lot of nerve muscle stimulators, which they use during surgery, and they check out in the dorsal, the dorsal most part of the psoas, whether the plexus is there. If it is there, then they work around, etc. So otherwise, for transforaminal, I have not seen, heard, not read also, but I'm open to read about it. Dr. Pal, in case you have any reference or any mention or case report, please do share with us. We will like to discuss that. Now, Dr. S.D. Singh is asking Bhupesh that in this case, that is the facet cyst, does it mean we have to do it inside out, the case of facet cyst?
Yeah, you always need to do inside out. First you enter the disc and gradually come out, so your orientation will be much better. Because here, when you are staying in the foramen, you are trying to do outside in approach, then you may not see the facet cyst. Sometimes it burst during your just clearance of the foraminal tissue. So it's always better you go first in inside the disc, gradually come out, see the facet, and do foraminoplasty, and gradually remove that facetal capsule and cystic part, and then gradually ablate it. That's it. I think outside in we should not encourage too much, because outside in there is lots of disadvantage also. If you go to Korea and you see the many surgeons doing outside in approach, you will when you see them, then you'll see, okay, transforaminal surgery itself is not good, because initial it's too much bloody. After 15-20 minutes you can see something, and then surgery finished, you will not realize. And sometimes patient may have pain and all these things. So always go inside the disc, come out, and take your orientation and do the surgery. This is what I
would
believe.
have a simple comment on that. If you look at inside out technique, you are going very close to the facet, to the outer border or outer wall of the superior articular process, and the cyst is actually coming from the front of the joint, that is from the joint edge. Okay, so if I'm talking about this facet, then I'm coming on one face of the facet, and the cyst is coming from this edge of the facet. That is where both the facets are meeting, where the joint is.
Yeah.
So what you have to do is you have to cut adequate amount of bone just to see the edge of the cyst. You don't have to remove everything.
Everything.
And
Yeah.
again, I will say that it will depend entirely on your ability to visualize the anatomy properly rather than jumping onto something. Because if you're not able to visualize where you are and where the cyst is, cutting things, as you rightly said, could be very bloody, could be very problematic. So that should be avoided.
Yeah.
Now, I think we are almost coming to the end of the program. This is 2 hours are over. So quickly, I would request anyone who wants to ask a question to unmute yourself, ask the question, or put it in the chat window. Otherwise, we will be going for the next session next time, that is on Wednesday, which is going to be more on lower zone stenosis, which is much more important because that is where we compete with all posterior midline surgeons, where they want to emphasize the laminectomy, the removal of ligamentum flavum, and all that. And I just saw, I think, Faisal join in. So in case, Faisal, if you have any comment, you're welcome. I'm unmuting you. So then if anybody else wants to have a comment, Dr. Ameya Parab, Dr. Suraj Kothari, I just saw they had activated their audio. So where is Faisal?
Faisal, sir, I'm here.
Yeah, okay, go ahead.
So mid-zone surgery, sir. I was just finishing one case now, so I just came in.
Okay.
Sir,
so, no problem. You can go ahead. No issues.
The discussion was going on, sir. Like mainly the mid-zone to concentrate on canal stenosis, mainly for the ligamentum flavum, which is just below the facet, and the contained disc, which is usually seen in younger populations.
Okay.
And then just producing a lateral recess stenosis. So I had one case, 21-year-old guy. He was a weightlifter actually. So he came with claudication symptoms.
What you could do is you could probably record the main details of the case and share with us the next time. Not an issue.
I'll do that, sir. I'll do that.
Yeah. So I think we'll conclude here. It's 5 o'clock. If there's any question, any comment, please do it immediately. Otherwise, in next 1 or 2 minutes, we are going to stop. As I mentioned, those of you who are desirous of getting our reading material and homework, please put your email in the chat window so that those who have not received it before, but please kindly be in time, arrive in time, so that all that share can be received in time and properly. All these things work on some bandwidth, so we need to be sure that we utilize the bandwidth properly and not vested. Sending it again and again sometimes is not possible. So with that, I would conclude today's session. I'm giving back the mic to Jayesh or to
Yes.
yeah, Jayesh. So please take over.
Yes, yes,
I
yes.
thank
Thank you so
you
much,
very
sir,
much, all the
once
team
again
from
for
Alembic.
this.
I thank all the team from Alembic as well as my colleagues, Dr. Shiraz and Dr. Bhupesh, who have joined us for this program today. Next program, that is the Wednesday coming, is our program on lower zone stenosis and its treatment, surgery for it. Again, will be primarily contributed by Dr. Bhupesh and Dr. Shiraz, and that will be Wednesday. Now, Amit Surana has
Yes,
raised
one,
his hand. What is it, Amit? Amit, where are you? Yeah, okay. I saw your
Amit, sir,
hand
you
is
can
raised.
unmute.
I'm unmuting you. If you have anything to say, please go ahead. Jayesh, you can unmute Amit. Yeah, no.
Sir, yes, Amit sir can unmute already, but sir is not unmuting. I'm asking sir to unmute, but the thing is that sir is not
Okay, I will
on
try once.
mute. Yeah, okay.
I think he may have to put his message in the window.
Yes.
And
Amit sir, can you please type in your query in the chat box?
yeah, Dr. Amit, please put your query in the chat box.
Yes, yes. Sir is unmuted. Yeah.
Okay, he's unmuted. Fine. Go ahead.
So next time, I think we should have a 5-minute session at least on the instrument, how we can use it, so that everybody who is new, they can, maybe able to know how the
No, the
instrument.
instrument session is the last one
Okay, sir.
because it will have to be repeated again and again. So what we have decided is, in the meantime, I will tell you that there is a big series of videos on my YouTube channel. If you search Google under the name Care and Maintenance of Instruments, those 3 videos are done by my colleague, Mr. Sunil Verma from Karlsruhe. So I'm writing the name, Mr. Sunil Verma. He's an engineer from Karlsruhe. He has done 3 videos on care and maintenance. Those you can see in the meantime. In addition, we will always talk about the instruments and explain to you our philosophy of use of the instruments, etc. So, is there anything else, Amit? Would you like
No,
to
sir.
say?
That's what instrument thing I want to talk.
Okay, right, fine.
Thank
So
you.
we conclude our session. Thank you very much to Alembic and our team from Alembic who have helped us in having this wonderful platform for last 6 times. We have now 2 more webinars which are pending. One will be next Wednesday and second will be next Saturday. So that will conclude our coverage of stenosis, which I think is extremely important topic for all of us as surgeons or clinicians. And thank you very much again. So over to Jayesh.
Yes, thank you so much, sir, for that kind gesture of yours. I'd like you to, thank you to give us an opportunity to conduct this stenosis webinar on our platform. And I'm equally thankful to all the speakers, delegates, and the faculty members who are very much consistent for this very much lecture on Wednesday and every Saturday. That is, they rope in exact at 3 p.m. in the afternoon and are not missing any of the lectures conducted by Dr. Satish Chandra Gore sir. On behalf of Gore sir and Alembic, I would like to thank all the participants who are participating equally and making this a wonderful event. So, as correctly said by sir, we'll once again meet for the 7th and 8th seminar which is being conducted by Mission Spine Foundation on the next Wednesday and Saturday. So, till then, I hope we all stay safe and we all take care of our health and we stay in pink of our health. Thank you so much, sir. Thank you, all the participants and respected doctors. Thank you, sir.
Yeah. Thank you very much and bye bye. Stay safe. Enjoy the weekend.
Stay safe, sir. Yes.
Yeah. Bye.